Why do giraffes have such long necks? Don't overthink it. The bones are longer, I would imagine. Because their feet are smelly. You have to remember, some of these were authored by my kids when they were young. Okay, so here's another authored original. You ready? Why did the hamster cross the road? Well, it was the chicken's day off. Okay, all right. What do you call a really big ant? Terminator? An ant might be afraid of a Terminator. A giant. All right, where did the whale play his violin? Where did the whale play his violin? The orchestra. Very well done. Okay. Today we're going to finish out transplant rejection as a component of hypersensitivity. And then we'll move directly from there into immunodeficiency diseases. So with transplant rejection, this is a type 4 hypersensitivity, and I want to talk about why it takes place. So on this graph, or on this figure, you can appreciate that there's two different pathways that are in play. There's a direct pathway down kind of the center, and then an indirect pathway down the right side of the slide. And really what this is an incompatibility of donor tissue into a recipient. Okay, so you've got donor tissue coming out of one patient. Let's take a kidney, for example, in this diagram, and it's going to go into a recipient patient. And there's going to be nucleated cells that are expressing different antigens. And primarily the antigens that we're most concerned about are the major histocompatibility complex antigens, the MHCs. And we will have an incompatibility either one of two mechanisms, either directly or indirectly. So let's look at the direct pathway, which involves an antigen-presenting cell in the graft itself. The antigen-presenting cell is in the graft itself, and it's showing antigen to either CD4 or CD8. So it's displaying an MHC class 1 or an MHC class 2 to the respective T lymphocyte. You with me? So let's go down this left side first. This is the direct pathway. It's direct because the tissue itself from the donor has an antigen that's an MHC1 or a 2, and it's going to directly activate a T lymphocyte in the recipient. Does that make sense why it's direct? So the antigen is already being displayed. The antigen is the class 1 or the class 2, and it's not a match for either T lymphocyte. So in the case of the CD8 MHC class 1, you're going to get into the circulation within the kidney itself, the renal blood vessels within the kidney of the donor tissue, and you're going to attack the endothelial lining because those endothelial cells have that same MHC class 1, right? And you're also going to get into the renal tubule network, and you're going to damage or attack the renal tubules because those are nucleated cuboidal cells, and they are also expressing the same MHC class 1 that it originally saw. Make sense? So you have sensitization that happened up here, and then it actually has activity and destroys the graft material. Now, let's look at CD4 on the indirect pathway, and you'll see that this pathway also bleeds over into the direct pathway. So the T helper cell, essentially what it does is recruit macrophages to come cause an inflammatory response at the level of the renal tubule. If we look exclusively at the indirect pathway, and both of these could be in play, and likely are, when you donate a kidney from one patient to another. So in the indirect pathway, you've got the graft cells, and the recipient, an antigen-presenting cell, like a phagocyte, sees that there's an expression of an antigen, finds it to be foreign, and displays it to CD4. And it's using this through an MHC class II display mechanism because it's helper T cells. And it's considered indirect versus direct because you're indirectly finding the antigen. The antigen-presenting cell in the recipient has to find the antigen and then go display it. Whereas over here in the direct pathway, the tissue itself has the antigen and your T cells in the recipient see it directly. So indirect pathway over here, it's displayed to the T helper cell, and we get a similar type of response with an activated macrophage infiltration, dramatic inflammatory response. And in addition to that, it recruits B lymphocytes to start manufacturing antibodies, and those antibodies are going to target the endothelium inside of the blood vessel, and you're going to get this vasculitis. So this is the problem that's happening at the level of tissue rejection with respect to tissue donation. So where does cyclosporine come in? So how do we combat this medically? Because we have situations in the clinic where we're having donors donate tissue all the time. Now, this issue that we're talking about here really is only a problem if you have nucleated cells that you're donating. If you're donating anucleated cells, like in the case of red blood cells, you don't have to worry about MHC classes. You actually have to worry about those blood antigens that we talked about last time. But here, you have a nucleated cell. If you're going to donate tissue that has living cells in it, you have to care about this. Now, there's a lot of examples of tissue that's donated cadaverically, and it doesn't contain cells. They take the cells out. And we've been doing tissue donations for a long period of time. So, for example, skin grafting. We talked about skin grafting in our wound healing section. We're taking donor tissue from a cadaveric donor and delivering it to a burn patient, for example. Now, you don't have to take the cells there. You actually decellularize it, and so you don't have to worry about this rejection. Bone is donated all the time. Corneal transplants. The cornea is avascular, so it really doesn't have any living cells in it any longer, right? And so you can have a lot of success with a lot of tissue donations that are decellularized or acellular. When we're talking about cellular donations, like in the case of a kidney, where you actually need the cells to have the functionality of the tissue donation, you actually have to suppress the immune system, and that's where drugs like cyclosporine come in. So cyclosporine is an immunosuppressant drug. It's widely used in post-allogeneic organ transplants, so that's same species, human to human, to reduce the activities of the patient's immune system. Does it completely eliminate? No. It doesn't completely eliminate. It reduces. So it was originally isolated from a fungus. And this fungus was found in a soil sample in Norway in 1969. And so ever since then, from a lab standpoint, we've been looking at synthesizing it. Now we have synthetic versions of it, and this is actually what it does. So if you go back to the last unit when we talked about co-stimulation, if we're looking at T cell activation of the CD8 nature, cytotoxic T cells, these cytotoxic T cells have to be activated by utilizing a autocrine release of IL-2 binding to the IL-2 receptor on the same T cell to activate it. And cyclosporine actually blocks that activity, so you get no co-stimulation, therefore no activation of cytotoxic T cells, or the CD8 positive T cells. What about your T helper cells? Are they still functional? Does cyclosporine have any activity on those? No, it doesn't. So that's still in play, and so over time, patients will develop antibodies, and they could actually reject the donated tissue even though they're on cyclosporine. Okay? We can actually deliver suppressants to the B cell activity as well, but usually the IL-2 activity is enough in order to eliminate that direct pathway that we talked about, and that usually buys the patient quite a bit of time. Okay? Kind of cool. A lot of medicine is taking things that we discover or find out in nature, and then we're using those compounds to actually have activity. So here's a perfect example of a fungus that's helping with transplant rejection issues in the clinic. Now let's pretend that IL-2 is not on board, or we're 10 years down the line from a donated kidney and we're starting to see elements of rejection because of that indirect pathway. We've developed circulating antibodies and now it's starting to take over. So let's take a peek at what happens here on rejection. So this is in the kidney. This is the glomerulus right here. So on the far lower left is the glomerulus, a hemotoxin and eosin stain section. You can appreciate the normal glomerular profile with enough open white space that's indicating the Bowman space. We're starting to see, this isn't exactly healthy, I would say. It's very early on in the rejection phase. So you're seeing this Bowman's capsule should go all the way around, and you're seeing it's kind of pinching off. So we're getting some swelling. So it's not normal, but it's definitely hyperacute in the early phases. Over here, now you start to see in panel B infiltration of inflammatory cells. So these are inflammatory macrophages that are coming in, just like we saw in the diagram. They're starting to create an inflammatory reaction against this tissue. As we progress from left to right, here in panel C, we're starting to see some scarring that's forming right here, and we still see the hyperpresence of inflammatory cells within the glomerulus. Over here, this is actually part of the vasculature. So now we're shifting over into a blood vessel, and this is the outer ring of the blood vessel, or the wall of the blood vessel, and this is all inflammatory infiltrate. In this little white space down at the bottom, this little sliver, that's all that's left of the lumen of the blood vessel. So now we've got this vasculitis that's taking place in end stage. If I back up 2 pictures, that's this picture right here, as well as what's going on in this picture right here. Okay, so trauma to the kidney tubules themselves in the glomerulus, and then damage or trauma from an inflammatory reaction associated with the vasculature within the donated kidney. So this is what would happen with any type of tissue rejection that's cellularized, whether it's a heart transplant, lung, kidney, okay? All of these transplanted tissues, this is what we worry about because of this hypersensitivity, which is a type 4 hypersensitivity damage. And you've got involvement of antibodies, but the reason it's a type 4 is because of the involvement of the T lymphocytes. Okay? So remember when we talked about the roadmap of hypersensitivities 1, 2, 3, and 4? I said that the 1, 2, and 3 are exclusively antibody, and then type 4 is considered T cell involvement. There could be antibodies that are involved, like what we're seeing here, but it's characterized classically as type 4 because of the T cell involvement. Questions? Okay, we're going to get into a couple of other specific types of autoimmune disorders in the last little section here. But I want to start out with this question. Why is this happening? So we've talked about, at the very end of Monday, we talked about diseases like Hashimoto's. We talked about diabetes mellitus type 1. We talked about multiple sclerosis. And so let me ask you the question, just to see if you guys are tracking. What is the cause of these autoimmune problems? What's going sideways?
B memory cells that are in the bone marrow are leaking out, and they're releasing antibodies that aren't supposed to be there.
Okay. They may not necessarily be B memory cells, but they are B cells. And so they're what we would consider autoreactive B cells, right? So you guys remember in the last unit, again, and I know this is review, and I talked about this on Monday, but I want to say it again to make sure you guys catch it. We have the opportunity to manufacture all sorts of creative types of B cells and T cells. The B cells and T cells originate in the bone marrow. The B cells mature in the bone marrow. If they're self-reactive, we trigger them for apoptosis, or we try to reprogram them, okay? And we call that central tolerance. If they're autoreactive and that mechanism fails, there's no way to prevent them once they leak out, like was appropriately just described. Once they leak out into the periphery, there is no peripheral tolerance mechanism for B cells in order to eliminate them. And now they're going to make antibodies against our own tissue in all sorts of different strange places, like against the acetylcholine receptor, against, right, the thyroid tissue. They'll make autoantibodies against a variety of different tissues that they're not supposed to do that. Does that make sense? Because the number one disconnect for students is, I don't understand why we do this. Well, it's not supposed to be this way, right? This is where it went wrong. Now let's take T cells. So B cells. So does it surprise you, out of the 4 different hypersensitivities, antibodies are involved in 3. 75% of the category are antibodies. If we would have had peripheral tolerance screening to get rid of autoreactive B cells, I would offer that we might have fewer type 1, 2, and 3 hypersensitivities. But we don't. So now you look at the 4th category, type 4 hypersensitivity, which has a T cell involvement, is less prevalent. You don't have as many of them. And you have 3 additional ways to screen for autoreactive T cells out in the periphery. You guys follow? So we'll try to screen in the thymus for T cells, and that's called central tolerance. And we won't reprogram them. They already left the bone marrow, so they can't be reprogrammed. They're in the thymus. We just trigger them for apoptosis. If they leak out of the thymus and they make out into the periphery, we can actually suppress them, trigger them for anergy, or trigger them for apoptosis. But every now and then, one becomes leaky, and we're going to get into some type 4 hypersensitivities that involve T cells. But we're in the space now, folks, that this stuff's not supposed to happen this way. And so I just want to take the pause, and that's what this slide is for, is to try to explain why is this happening. And so you can see on this slide, we've got susceptibility genes. Genes that are susceptible for mutation or faultiness. And it leads to a self-reactive lymphocyte, whether it's a B version or a T version. And we do not find it. We have failure of self-tolerance. Okay, that means we didn't find it. Our central and our peripheral tolerance didn't work. And now we've got sort of this influx of self-reactive lymphocytes into the tissues, and that's what's causing what we refer to as autoimmune problems. Okay? So let me ask this question. Does it make sense to you that an autoimmune disorder could show up at some point later in the patient's life? Or does it make sense to you that they should always have had it? Which one should it be? Which one makes the most sense? Could somebody be born and very early have an autoimmune disorder? Yes. Do you think they could develop later in life? Yeah. Both make sense to me, right? So some students are like, well, why is it that some people develop MS later in life then? If it's a genetic problem and the self-tolerance mechanisms fail and they start making autoreactive T cells, why does that happen when they're older? Help me answer that question. I think you know the answer. Go ahead. What's that? Thymus is shrinking? Yeah, the thymus gets smaller. Your ability to screen for self-tolerance is compromised as you get older, okay? So autoimmune disorders actually can and do show up more prevalently as we age. Remember, age is a pathology. So as we get older, our ability to self-screen becomes compromised, and one of our critical organs actually shrinks. We already know that. The thymus actually gets smaller. And so our ability to self-screen isn't as good as when we were younger. So it should make sense to us intuitively, pathologically speaking. You might see the incidence of autoimmune disorders increasing as the age of the population goes up. Okay? Now, there are some triggers. There's definitely genetics. There are patients that are absolutely born with it. There are infants that are type 1 diabetes patients. They, from the get-go, have attacked their pancreatic beta islet cells. Okay? Now, the good thing with type 1 diabetes is usually patients respond really well to glucose monitoring and then delivery of exogenous insulin, right? So they have to give themselves their own insulin. And we have all sorts of different types of insulin now. It's actually become pretty sophisticated. And glucose monitoring now is becoming less invasive. In fact, Google's actually got a project on a contact lens that will monitor glucose levels. Okay, it's pretty cool. And I've seen some of the prototypes in some of these conferences that'll display on the contact lens a little digital output of what your glucose number is. Okay, how do you like that? So you're sitting there right there, and it's just like, 72 pops up. You're like, ooh, I should probably eat something. Okay, pretty neat. Okay, so let's talk about the breakdown of these self-tolerance mechanisms as it relates to one of our first type 4 that I want to dive into in great detail. This one is systemic lupus erythematosus, or SLE. Now, systemic lupus is the most aggressive of all the types of lupus. It's systemic, meaning it's all over the body. There are really 4 types. There's systemic, there's cutaneous, there's drug-induced, and even fetal. But the one, for our purposes, that we're going to hone in on is called SLE, and it does happen to be the most aggressive. There's an autoimmune issue associated with, mostly it's been described as being nuclear proteins, or what we call nuclear antigens. So something within the nucleus is the antigen that you're responding to. Now, the problem with systemic is that could be located all throughout the body of any nucleated cell type. Okay? So the significance is really tied to kind of the wide disbursement of nuclear antigens or nuclear material. So what this is saying is, inside of the nucleus, there's some antigen. So if you have a nucleated cell, you have the potential that you have a self-reactive antigen. So that's fairly, I'll use a word, ubiquitous, meaning it's everywhere. And that's why SLE, or systemic, is so problematic. There's thought to be 2 big initiators here. And one is definitely heritable traits. So there's a genetic component of inheritable susceptibility. So for example, class 2 MHC, something goes south with class 2 MHC. And because class 2 MHC is found on many, many nucleated cell types, you've got a problem there, okay? That's not a nuclear antigen, that's actually a cell surface antigen, and that's why it says other self-antigens in this box. Some other ones could be susceptibility to complement, where you actually are reactive towards the complement that your liver is making, which is a protein that's circulating in your blood. So everywhere the blood flow goes, you could have an inflammatory issue. That is really problematic, okay? The second initiator is very poorly described in the literature, less understood. But these environmental triggers, where patients will have phases of their life where their lupus is under control, okay, or it doesn't flare up, and other times where it actually ramps up. And so UV radiation has been identified, or sunlight, a severe exposure to sunlight. In some patients, they can kind of point back to a period of time prior to which they didn't really have, they were asymptomatic. They were probably carrying traits for lupus, but they were asymptomatic. And then they spent like a week at the beach, and they got dramatically sunburned. And as they recovered from that, the lupus symptoms started showing up. Okay, and that's actually very common in a lot of types of autoimmune disorders, where there's a lot of times there's some sort of triggering event, okay, that takes place. I'll tell the story. I'll probably tell it again when we talk about endocrine, but we were with a group of friends on a family vacation. We were up in Santa Cruz on the boardwalk, and there's a couple of families, a bunch of families that were there, and this one young man, basketball player, played high school varsity ball and was getting looks by colleges. So kind of classic basketball player physique, very tall, very lean, okay, great shape. They actually went to the boardwalk, and they had to call the paramedics because he passed out. Well, he had 4 funnel cakes. I don't know if anybody knows what a funnel cake is. He had 4 funnel cakes at the boardwalk that evening. The boardwalk in Santa Cruz has all these like rides and stuff like that. It's kind of like a state fair, but just miniaturized. And so he had 4 funnel cakes, and he went into a sugar coma. And they rushed him to the emergency room, and his blood sugar levels were north of 700, okay, which is ridiculously high. Like you're probably going to go into a coma if you're not careful, okay? And so, I mean, typically low when you're hungry is like in the 70s, okay? And then after a meal, it might spike up, 150 to 200, and then it's going to settle down pretty quickly after you're kind of relaxing. So 700 is really high. He was diagnosed with type 1 diabetes. He's a type 1 diabetic, but he's like, 18 years of age. He'd been fine up until 4 funnel cakes. And so the theory behind it is, so the pancreas, the beta islet cells, has slowly been attacked over time. They were probably right on that knife edge of tipping over into symptomatic, and then he bombards the system with 4 funnel cakes, and that's actually what puts him into a type 1 diabetic situation. Does that make sense? So these environmental things, these triggers, are very, very common in autoimmune disorders, or someone gets a dramatic fever, like a flu, and then after they recover, they're never quite the same, and people are like, well, that's weird. So-and-so seems a lot different. So what does this look like? Well, again, this is systemic lupus. These are always, interesting. We block out the eyes because we don't want to be identifying, the patient, but, so if they walked in right now because the boxes aren't there, you wouldn't know it was her, right? But we do this classically in clinical images just to try to, I guess, protect the identity of the patient. So some of the cases or clinical symptoms that will happen with patients are a lot of skin erythema. So that's a term, erythema, meaning red. So you get a lot of redness, and what I want you to be able to depict here is sort of this butterfly rash over the bridge of the nose because of severe inflammation that's happening within the dermis. So this is a young lady that has what's called a malar rash, M-A-L-A-R, and this is the butterfly rash that crosses the bridge of the nose onto the cheeks. You see this in systemic lupus, and you see this in discoid lupus, which is another word for a skin lupus. You'll also see these kinds of inflammatory issues, although we can't picture it on the screen, but you'll see it in the joints, and you get a lot of swelling. You'll see it in the kidneys because it's highly vascularized. And you'll even see a central nervous system issue or involvement, meaning the brain. And the reason for that is because of all the microcirculation in the brain. If you have vasculitis, now the brain itself is getting basically starved of oxygen flow. Okay? So we call this all under the category of acute necrotizing vasculitis. And so what's happening is the blood vessel, the endothelium of the blood vessels throughout the entire body are being attacked. And you're getting lesions that occur in the vasculature. And that's the vasculitis that we're referring to. Okay, so this is a type 3 hypersensitivity. a type 3 hypersensitivity, systemic lupus erythematosus. And the reason it's a type 3, because of the antibody response that's being manufactured. And what is a type 3? Do you guys remember to the board over there, the type 3? It's an antibody and an antigen, and then they circulate and they get trapped and they get stuck. So does it make sense they're going to get trapped in the joints, in the kidneys, as well as in the vasculature? Okay? So you remember back to Monday, we had a slide up there that talked about kind of 3 main areas that these type 3 antigen antibody complexes get trapped. And they're most profound in systemic lupus patients. Okay? They have all 3 symptoms, unfortunately. So a type 3 example. Shifting to a type 4, so we went type 4 when we first started with transplant rejection. We did lupus, which is a type 3, and now we're back to another type 4. So this is rheumatoid arthritis. Rheumatoid arthritis. Now, let me pause for a second and describe the difference. So we talked about reactive arthritis, right, which is a type 3, because that's what's happening in the joints. This is rheumatoid arthritis. And then a lot of probably your parents and grandparents complain of what we call osteoarthritis. So what's the difference between the 3 different types of arthritis? Reactive arthritis is an antibody mediator, and that's a type 3. Rheumatoid is a type 4 because of T-cell involvement, and we'll show you that here in a second. And then osteo is nothing to do with an immune response. Osteo is just old age or overuse. So you have bone on bone where you're starting to get inflammation happening because you're rubbing bone to bone. So it happens in a lot of your parents, your grandparents, you know, if they were active when they were younger and they threw the ball, they were a pitcher or a quarterback, it'll be osteo in that throwing arm or that throwing elbow. Okay, if they were a tennis player, it would be in the dominant arm. If they were very active and they're having a lot of arthritis in the hips or the knees or the ankles, oftentimes it's worse in one side, and it might be bilateral, but it's definitely worse on one side, okay? Probably the one that they kind of, their dominant side ends up getting more use, and that's the one that has most wear. Whereas in rheumatoid arthritis, it happens bilaterally. You're not going to see rheumatoid arthritis only happening on one side of the body. It actually targets ubiquitously the joints, okay? So the etiology is, the thought process is the erythrogenic agent is a type 2 collagen. It's thought to be that there's a hypersensitivity to type 2 collagen, which is found in many different places in the body. And now this sort of erythrogenic agent, this antigen gets presented to T helper cells. T helper cells activate B cells and they make antibodies. They stimulate the macrophage, and they actually cause trauma to the endothelium based upon this inflammatory cascade. So CD4 in the joints, we've got sort of 3 activities that take place. Obviously there is B cell involvement, so we get the formation of autoantibodies. So this is a type 4 that I was kind of warning you about. It is a type 4 that has antibodies, but it involves the T cell, and that's why it's classified in the textbook and in a lot of medical literature as a type 4. So remember in the very beginning I said these are our categories that we try to nice and cleanly segregate, and not everything in biology is going to fit into a nice little bucket. So the rheumatoid arthritis has been widely debated. Is it type 3 or is it a type 4? For purposes of our class and for the exam, listed as a type 4 because it's got the T cell involvement. Does that make sense? But if you move on to medical school, don't get into like a fist fight with your professor about type 3 versus type 4. Just understand that there is some disagreement in the literature on how to classify rheumatoid arthritis. It is a hypersensitivity, but you may, at a cocktail party, fall on a type 3 category argument or a type 4 category argument. Okay, fair enough? So what's going on within the joint? Well, let's take a look here. So we've got In rheumatoid arthritis, we've got issues at the level of the joint and at the level of the skin and in the vessels themselves. So most of what we pay attention to are the joints. And you've seen pictures of patients that kind of have like, curving fingers. It happens in our older population because the rheumatoid problem, the autoimmune problem, has been happening for a longer period of time. But so this is a classic example. Most people think that kind of like the gnarly old people crooked fingers is a autoimmune disorder of rheumatoid arthritis. And again, it seems to be only attacking this older population. Well, no, it probably began younger in life, but as the patient aged, it got progressively worse. And then the ability for this atherogenic agent to cause problems was accelerated, okay, because of the aging process in the patient. So this is dividing the joint right down the middle. We've got a normal joint on your left. We've got a rheumatoid joint on your right. And what I want you to be able to appreciate is the collagen, the type 2 collagen that's present within this joint space is encouraging the recruitment and the activation of these immune complexes. And these antibodies are forming. The neutrophils are being recruited. You've got lymphocytic activity. This would be a T helper cell that's kind of getting this whole thing going. Recruiting the macrophages as well as the plasma cells to manufacture those antibodies, those autoantibodies, and you've got this inflammatory flare that's happening right inside the joint. And the inflammatory area that we're referring to is what we refer to as pannus. So pannus is defined as a mass of synovium and synovial stroma that's infused with inflammatory cells. So it's basically like granulation tissue that we see in inflammation, but it's in the synovial joint. Okay? We've got this condition known as ankylosis. This is from the Greek that means bent or crooked, ankylosis. And so what ends up happening is if you've got inflammation on this side and you don't have it on this side, which side is the joint going to bend towards? It's going to go this way, right? Because this stuff is increasing and swelling in size. Now the joint's going to bend in this direction, and that gives rise to this ankylosis look and shape. Okay, so what's happening in these two panels? So in the middle panel, we've got histology that's looking at the inflammatory infiltrate that's showing up within that synovial space or in the pannus. So this is histology of the pannus. And then here we're blowing up in higher magnification. You can see all the purple dots, right? We know now at this point in the semester that all that purple nuclei is indicative of an inflammatory flare. And if you zoom in higher magnification on the far right, you can see all the inflammatory cells within the synovial fluid. It should essentially be clear. Synovial fluid should be clear. It should be mostly pink in this slide. Over here, you can appreciate all the purple dots, and then you've got the arrows. These arrows are actually lymphoid aggregates. So this is basically like a lymphoid aggregate would be a bunch of helper T cells or T lymphocytes that are actually bundling together. Okay, that's what the red arrows are pointing to. So you've got all these macrophages in purple, and then the red arrows are pointing to a collection of helper T cells. We don't actually know if they're helper T cells. I would just call them T lymphocytes or lymphoid tissue. All right, what does it look like? This is a progression of the same patient over time. So we've got arthritis that takes place throughout the body. We see it in, let's back up one slide just so I can tell you this. This whole thing that we're describing that happens in the joint, it happens in the skin, and you get what are called rheumatoid nodules, okay? It happens within blood vessels, and you get a vasculitis that's happening and causing an obstruction. So when we look here on this slide and we talk about the different organs that are affected, we could put joints, skin, blood vessels, and then we do see it in lung and in muscle. And the reason likely for that is because of the vasculature that's present in those tissues. So rheumatoid arthritis, we have this ankylosis or this bent, like crooked Very pronounced in the fingers in patients. It's episodic, so it does flare up, and then it might subside over time. We talked about this being symmetric, meaning that patients that have rheumatoid arthritis, if you look at their hands, they're going to have the ankylosis on both hands, okay, unlike with osteoarthritis. And we've been able to identify a rheumatoid arthritic agent or a factor like a collagen 2 in greater than 80% of the cases. In about 20% of the cases, they don't understand why it's happening. We just know that the autoimmune disorder is taking place. So let me draw your attention to these radiographs, and then I want to show you guys a table that's from a different textbook, but I think it'll help summarize and be a good study tool. And that's the last slide for this particular lecture. So here early on, you're seeing pitting. Do you guys, this is a blow up of this joint right here. So you could circle this joint, and if you blow this up in this arrow, you can see that there's a little notch where the bone is eroding. So what's happening in this patient is you're getting this inflammatory process that's taking place, and over time, it erodes the bone. And you can see this radiographically by the disappearance of bone density in this particular patient. Over time, as this patient progresses, I want to draw your attention to the first two digits, right, or digit 2 rather than 3 if you ignore the thumb. And you can see that the spacing here, right, there's a little bit of white highlight. That little white highlight is showing an area of inflammation. Now look at these two joints. They're actually fused, right? There is no space between these two joints any longer, indicative of the progression from the patient from an early onset to a later onset. Okay, this is the slide that I was talking about where we've highlighted, this is from another source, but I think it's actually a really nice study tool that it gives you in columns, type 1, type 2, type 3, and type 4. Okay? And it talks about characteristics. You can see the respective antibodies that are produced in the first 3 types. You can see characteristics about antigen, how long, what it looks like histologically. You can see it's transferred with or associated with antibody, 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 and then T cell. And then there's a category of a number of different examples for you. Okay? Just to help put a picture of how to organize all the information in 1 through 4 hypersensitivities. Questions? Clear? Great. No questions, huh?